Good morning, everyone. We would like to welcome you for the 11th Forum of Health and Vigilance, Public Health. Now we're going to be covering the experience if there is an emergency, a public health emergency, which is of international importance. Just to quickly acknowledge all of the authorities and also those that are connected through our social network. In the Andean Organization for Health, Hipólito Unani. I'd like to invite you to please accompany us during the entire session and to continue following us on your social media. Today we're going to be covering experiences and everything that academia can be doing to improve our response capabilities if there is any sort of public health emergency. Possibility is that future professionals, teachers, etc., can bring more with their investigation and projects to share experiences with their health teams, which at this moment are at the front of the institutional response to COVID-19 and other illnesses, which are high-risk illnesses. Today, we're going to begin this session having presented Dr. Gabriel Carrasco. He is the Innovation Health Lab from the Peruvian University, Cayetano Heredia. He's going to have a presentation about academia, vigilance, and epidemiological control, collaboration experiences between UPCH, London School of EM and Tropical Medicine in the University of California. Gabriel Carrasco is an investigator in University Cayetano Heredia, the Scripps Institution of Oceanography in California, San Diego. Investigations are focused mostly on epidemiologically infectious diseases and determination or detection with limited resources. Specialized in methods for epidemiology, spatial analysis, remote perception, and data science to understand the roles of human mobilization and macro composition and micro geographic composition of the environment. As regulators of this dynamic for dengue, tuberculosis, and cholera in rural or urban areas, Dr. Gabriel Carrasco, you have the floor. Please go ahead. Thank you very much, Dr. Bencolea, Dr. Calle, for your invitation. This is a very valuable place to be able to generate more conversations about what we can bring to academia and also to have a very broad discussion about how we can face different challenges to health vigilance. Okay, so I am going to begin by speaking about the contributions that we've been able to make in the last 3 years in our lab, in our health innovation lab, based basically on a network of collaborations, broad network of collaborations. And I think this is the way we should be moving forward, basically, and how we're facing these types of problems in the public health sector. We're going to be speaking a bit of two specific problems. I'm going to be talking about malaria, and I'm going to be speaking of climate change or the environment. Now, these are, well, malaria on the one hand is one of the most significant illnesses against public health, and before COVID, climate change is the largest threat in the next decade. Not to begin with, and just to put this into context, malaria in Latin America, it was being reduced. There was a significant reduction in the number of cases, mortality of malaria, and it was between 2005 2014. But since 2015, this tendency has reversed, and now there is a rise, a stable rise in the number of cases, the number of deaths caused by malaria in this region. the majority of these cases, or the majority of this reversion of the trajectories, are coming from the sanitary, political, and social crisis that we have in our neighboring country from Venezuela. But there are other countries that are also bringing a significant number of cases, mainly because of the context, the environmental context where this happens. Now, we can see on the map on the right, the majority of the areas, transmission areas for malaria occur in an Amazon context. And this involves countries like Brazil, Ecuador, Colombia, Venezuela, Peru, Guyanas, and other countries, which are more or less close, such as Brazil and Venezuela. And of all of these regions, or all of these areas, the challenge in this case, well, Loreto, for example, which is the Department of Peru, is Area 5. It has a very high level of transmission of malaria, and that's why we've used Loreto as a study case for the majority of the investigations that we've carried out. Now, again, just to place this into context, if someone is not coming from the field of malaria or infectious diseases, malaria is transmitted by a mosquito in general, Anopheles, and in the area, the Latin American region, it has a sort of species of gender, which is Viserincos carni, and this species is just different than its cousins or these other mosquitoes in other areas, such as the African or other subspecies. They are more plastic. They're more flexible in their regime, their feeding regime, and well, their bite regime and other characteristics in their behavior. Now, there are also two species of, well, they are very important for public health. Now, these are the ones that are causing illnesses with different clinical profiles. In Latin America, the highest load or the largest importance of these species. But Plasmodium, this is significant for the rate that we have. And having said this, in this context in the region, we're going to be going to Loreto. We've mentioned this is part of the study area. Just Loreto is accumulating over 90% of malaria infections on a national level in Peru. 80% of these cases occur because of Plasmodium vivax, which is one of the two species of malaria that we've already mentioned. And a lot of the investigation that we do carry out because of malaria in Cayetano have shown how this mosquito is very plastic, very good at finding new places to be able to transmit and how they can find new ways of transmitting disease. And so this is particularly important, and this is a study of a modeling study that we carried out not long ago, a couple of years ago really, and it's where we were profiling the time that it takes for one person in all of the centers, populated centers of the country, to reach the closest health center. And as we can see in the right, the areas in the jungle, particularly the area of Loreto, the communities can take up to 3 days in being able to reach a health establishment or a health center. Now, this means that they have access, which is very limited because the majority of the communication is through rivers or other ways of communicating that do not allow for this rapid communication. And this means that there's not the amount of health establishments that perhaps this type of population requires. But what happens in this area? We've titled this as, well, a socio-ecological dynamic, a vibrant socio-ecological dynamic. And as you can see, or you guys can see here in the video, these are some captures, satellite imagery, and we can see how the hydrobiological dynamic in some of the areas can be very drastic. It can happen very drastically. And this added to what you can see on the left, there is an urbanization process, which is very explosive, very quick. So modification of the environment as a natural area, the expansion of urban areas or populations of others in these areas, it then creates this perfect context for transmitting these new illnesses, amongst which we have malaria, and we're also talking about dengue, HIV, tuberculosis, etc. Now, this is particularly important for this type of illness because, as you can see on the right, all of these areas in Loreto, they are placed on the uh, basically on the sides of the river on the hydric area of this region. All of the communities, they all depend in one way or another, uh, in a direct or indirect way, they depend on these hydrobiological dynamics.
De disponibilidad de agua. Entonces hay mucha interacción en términos de seguridad alimentaria, movilización humana, pero sobre todo en dinámica de vectores y agentes
and vectors, parasites and infectious parasites. In this context, we will speak about the road to malaria elimination, the decision that Peru has taken for some years, and it's an example of this interaction, academia and state. This road starts by the academic initiative led by Alejandro Llanos and Hugo Rodriguez, and many institutions, the Cayetano University, and in the Amazon that have provided knowledge in this chain to the elimination of malaria. We are going to summarize three main phases. The phase of control, when there's still transmission and the main objective is to reduce the amount of cases. The phases for elimination, when we have less than one cases per 1,000 population at risk. And when we confirm that we have 0 cases, locally there is a phase that is called prevention of reintroduction. After 3 years, we can check that there are no cases, and then there is a certificate for the country. Peru, as I said, is in this process, and we have finished some control phases, and we are starting into some elimination phases. And this is what I'm going to show you as part of our research this last years. What you can see here is the story of the disease in the last 20 years. The number of cases of malaria per number of inhabitants, and we have it for Plasmodium vivax and for Plasmodium falciparum, the two dominant species in public health in Peru in this time. And as you can see, is a seasonal was a seasonal phase, but there have been moments in which there have been a series of cases and moments in which transmission has reduced or has limited due to natural factors, but also due to interventions of the health system. And this is where we start with surveillance systems. We are going to speak about two moments or two interventions that are important or successful in the history of malaria. The first one is called PAMAFRO, which is financed by World Bank. And
y el control de la enfermedad en base a distribución de mosquiteros, capacitación de agentes
Well, they give bed nets and train technical staff for microscopy. And next to the community, they remove the points of reproduction of the mosquitoes, and this went from 2006 to 2011, 5 years, and starting from 2012, after this intervention, we started malaria started to return. And this part that you see here, when there is no intervention, where we return to malaria levels that we haven't seen even before Panmafro, that is the vector or reservoirs of parasites was latent, and it returned with enough power to have higher transmission levels. With these lessons learned, the government of Peru starts the plan Zero Malaria, which is a plan that is financed by the Peruvian state and focused on Loreto region and with new activities for the control of malaria. We have seen a reduction in the number of cases, and from 2020, well, we have the pandemic, and we had series of problems in reporting and competition in the surveillance system due to the lack of staff and other challenges that they have covered in this format that we could speak further on.
Esta, estas dinámicas o estas fases de
These dynamics or these phases of intervention do not have the same form in all the provinces of Loreto. What we have done here is to divide this data that we have at the Loreto region for each one of the regions. And we see that in minus, for example, we have an explosive uprise of cases, but it's not the case for all the provinces. There are other patterns like in Marañón or a reduction in transmission in Ucayali. So what is the first thing we did in this collaboration next to the Ministry of Health is to assess both interventions and where did they contribute and in what way? So just as an example or to explain what was the methodology that we used, we are going to cover one intervention, the case of Mamafro, and one case which is P. vivax cases. There are two species. Remember that are vivax and falciparum, and this is the cases for one province, the province of Mina. So what did we do in the pre-intervention process? We had the data, that line in black, which is the total of cases observed. And what we did was to modulate these cases. For this modeling, we use artificial intelligence and we used some additional methods, and we tested the Google and Facebook algorithms, and we checked some time series and neural networks, but uh, we could speak about that in the future. But in the end, we end up with a joint model that allow us to modulate or to model the cases based on three environmental parameters: temperature, precipitation, and deforestation. Well, that model that allowed us to have a estimation of the real number of malaria cases. Once we had this model, we projected what would be the number of cases that we should expect if there is no intervention of the state. And with this, we mean projected cases or contrafactual factual cases, and we compare it to the real scenario. What was the real number? And we repeated this for malaria or Pamafra for P. vivax and P. falciparum in all provinces in Loreto. This is how it looks. We have the factual projection and the real observed cases. These two diagrams, left Vivax and B falciparum, represents a monthly estimation. That is how much was the effect or the monthly impact of both interventions. We will see in red Pamafro and this Malaria Zero program. And what we will see in these cases is the median of the impact, the summary. What did we see? Two main characteristics. One, an impact on Vivax more than positive falciparum. Falciparum is more, oh, there was a higher impact in Pamafro compared to malaria zero, adjusted by time. Um, the zero malaria plan was a shorter operation time than the 5 years of the Pamafro project. And this impact, so this reduction in the cases of malaria is not homogeneous. There are areas, as in the northern part of Peru, that the Department of Loreto, where we see a higher impact in some areas in which we see more cases than we expected. The intervention did not work. And after discussions, well, this has related with accessibility. It has to do with the strategies of the control strategies, adherence, and to these strategies by the population that in some cases is native and requires a differentiated process. Well, the discuss this with the people in charge of the zero malaria plan and the strategies for the control of malaria at the national level, but in our lab, and Jasmine Cayone Villa started to do another question, which was to understand if the relation between some climatic parameters and malaria was stable in time. That is, if the relation between malaria and temperature, for example, was maintained along all the years. And why is this important? Because this will allow us to generate more prediction models, or it will allow us to assign control strategies in areas in which we could predict the effect with a climate. There were three important messages in this publication. First of all, both species react, or they have a reaction, a different reaction with climate. This was reported not in a solid manner, especially in the Amazon and in the region. The second thing is that the environmental factors differ in absolute and in trend, in absolute terms and in trends. And this, um, and the third, which was the what it was most interesting, was that this relation between malaria and climate is exacerbated in between the control periods. These farms are the periods. In this case, is a permafrost project, and during that period, the what we are seeing here is the responses between climate and malaria. We are seeing transpiration, and we are seeing temperature, and especially in transpiration, this relation of one value, an average value or pre-intervention value, which is reasonably stable, that the starts to decrease and becomes more negative, and it starts exacerbating. The relation becomes stronger. That bond link between malaria and climate becomes stronger as the process of the project Malaria Zero Permafro, excuse me. And once we finish the Permafro project, the return to pre-intervention levels lasts between 5 to 8 years. And why is this important? Um, this means that the cases that remain have a more specific bond or relation with the environmental conditions, as ponds for uh, egg laying, and sites where mosquitoes lay eggs, and it has to do with intrinsic uh, uh, capacity of the humans and the mosquito linked to climatic changes. This was very interesting, the sensitivity to climate by moments of the control. And what we did what we did was to analyze the relation between climate and malaria at the level of Loreto. We started to use satellite images, and we um, use variables as climate, precipitation, and other social and operational variables of the regional health office of Loreto to put it in the model, which is in a space model. I'm not going to speak in detail about this, but after the calibration of this model for both species, for Vivex and Falciparum, we found that there were trends in climate factors and deforestation that provided to understand the dynamics of both species. This is important because the dynamics different than what we have reported are not dynamic. They do not feel linear dynamic, but they have non-linear dynamics are related with critical points or moments of deforestation, peaks of deforestation that induce to a better transmission of malaria and have other different values. This is known as malaria frontier that has been described in the Brazilian Amazon. There are elements of the development of a city where we invade a new area, we deforestate, the interaction between mosquitoes and people is higher, and then the cases start rising. Once we establish that and there are more services and there's higher dynamics or more dynamics, this manifestation makes it not a good habitat for mosquitoes, so transmission reduces. This is the first time we report this similar dynamic or this pattern of the frontiers of malaria in Peru. And we have been able to see that, or the contribution of each one of these characteristics, climate, forestation, and malaria control are not the same in all districts of Loreto. That means that there are some areas in which deforestation is the key factor for malaria. That is, we are not going to be able to finish controlling malaria if we don't intervene or we um, look at how deforestation happens and all the complexity, social complexity that exists. In other districts, we have other climatic conditions, and we have seen how controls are different. In what the districts to train community agents was useful, in what districts to train microscopists was effective or contributed to the to malaria, and in what districts it didn't. And this improves the strategies of control and does not provide a single package to all of them. There are districts that require a different strategy. And the message is that there is, even though Loreto can look a homogeneous place, it exists a social diversity that we need to take into account to design better control strategies. And this is the next step by the regional health office to improve the strategies to have evidence on what are the um, contributing factors so we can make the better decisions. Let's go back to our control route and or road control road, and I'm going to show you two projects are related with the elimination phase and the prevention phase, related with projects that our lab has conducted to innovate in the use of strategies for the control of malaria. We have two projects. The first one is determining or characterizing the environmental component using drones, and the second one is understanding what is the role of social mobilization in the transmission of malaria. And this has focused on this prevention part where there is a mobilization of people between different places. If we have control of the transmission of malaria in one area and we have people from another place, this is called importation risk. And we have seen that with COVID, when people mobilize, it contributes and favors the transmission of the disease. This is well known for some time, but what we needed to do in Peru was to quantify it, and this is part of what our lab has done. So what did we do? We do an initial proof of concept for the drone project, not for our projects, but especially for the drone project. What we wanted is to have better images to understand the environmental dynamics of the study areas. We use a regular drone, RGB camera, but we use a multispectral camera to be able to see all the wavelengths, to see the light, and to have the data of the light reflectance. This project is one of the most important in our lab. And what we did was to mount the sampling larvae um, initiative in 4 of the communities, 8 water bodies per village, and we used 2 drones. The um, drone for RGB mapping and MS mapping. For the 4 communities, we have more than 3 GB, regular pictures, more than 20 gigabytes, multispectral pictures. And what we did was we aligned them. We Each one of these pieces is aligned in space. Consider the angle in which the picture has been taken, and we create certain models called orthomosaics based on the alienation of the images. This allowed us, well, these are the four communities that we have analyzed if we use data available by satellite imaging. This is Landsat 8, which has a resolution of 30 meters per pixel. Every pixel in the image represents 30 meters. We pass from this resolution and this type of information of our communities to this type of information. This is the data from our Phantom 4 that has a spatial resolution of 5 centimeters per pixel. So as you can see, the additional information is enormous. How much more information can we have to take better decisions or to optimize our resources and to focus where we are going to um, use where we want to have urban growth or understand where are the forestation areas. And this is what we obtained, orthomosaics, a collage or panel of our pictures reflecting in high resolution the distribution of the communities, but also we were able to obtain 3D models to try to analyze digital elevation models and models that are related with fluid dynamics and reproduction science. Until here, we were able to identify the maps for the malaria control, but we wanted to calibrate a model of machine learning to help detect which water bodies, what ponds and lakes had the highest probability of having mosquitoes. So we used, and I'm going to show this very quickly, but we use all multi-spectral bands. We covered our interest areas, and we use three approximations for classification. The main difference is what is the advantage for to detect um, better better the reproduction sites. So with these approximations, the first approximation was to detect the water bodies and all the characteristics. The second approximation was to detect the same, but to divide water bodies between positive and negative. And the third one was only water bodies. Let's forget about the other characteristics. Let's focus only in water bodies. In the three strategies, we got more than 85% of precision. That means that detecting the water body and assigning this to the model, it has 85% of chances of being really a water body that has mosquitoes. So this is a very useful tool and allow us to control strategies, not to spend resources in searching all the water bodies in the zone and sampling all water bodies. in the zone, but to focus efforts. And this has two consequences: to be more optimal in resources, and also it reduces the probability of generating resistance to the pyrethroids or other substances to kill mosquitoes. Actually, the research team has been showing how resistance has been increasing in the last decade and has been increasing at an alarming speed. That's why this new type of technologies allow to optimize the use of resources, allow us to control and to have a set chemical set that will allow us to control this disease in the next years. We understand that in Loreto and other areas with limited resources, computational capacity is limited, so we generated an online um, platform using the Google Earth Engine app. We create the algorithm, we upload it so any person with internet access that has a drone to this type of work could add their data in this application, and the application will tell them what part there is more probability of having positive water bodies for mosquitoes based on the investigation that we have made. So the intention is to break the barrier of resources that are used for this type of research and to try to include it in a more operational manner in surveillance systems. This is super interesting, but even though they believe that the absorption of these technologies is very complicated for people, um, uh, common people. On actually, after 2 weeks of training, our field workers were totally capable of taking the routine, the drone routine. And this is because a great part of what we have designed for drones is automate the flight routines, the calculations, height, resolution. Most of the workflow is already automated from Lima and Alba, and staff have control of when it can happen and they feel secure on the field work. We have had many interactions with the health division, and it does help us in the introduction of these new technologies. Finally, we have a group or a network called Macondo, in which, well, I would like to invite you, but if you want to learn about these technologies or that already use these technologies and would like to make part of a support network in sharing resources, understanding how we can use these strategies better for the malaria control, are welcome. Also, I wanted to share the work of several years in our lab on malaria. And when we started to have these ideas and try to prove and contrast our hypothesis, we didn't have much budget. Actually, this part of the studies were not financed, but they were added into bigger studies. But we started with a mapping participant participatory mapping. We had a tablet and we asked people to tell us what is the route to go to school or their daily activities. This publication, this was published already a couple of years ago. And what we were able to find, we were able to characterize, we were able to characterize their migratory patterns or their mobilization patterns, actually. Uh, and we discovered what were the routes that they used for timber production areas that were not identified before in any other research work. We could understand what were the transit areas in this small area, which is Masan, the district of Masan in Loreto. And what is important is that the logistic expense is quite small. Next to a survey, they had to draw their daily routine. We were able to characterize economic activities or daily activities that involve or favor the mobilization of people. We identified what type of agriculture, what type of fishing, what type of um, logging, they that force people to have longer trips or shorter trips. These were able to be used for surveillance. Then what we did was to create a GPS. And because we have little financing, we printed it and we have a one for traceability. And any person that can download this can create their own GPS tracer, and we give it to people to see it indirectly what is their how is their movement and how this can impact malaria. We found very rich detailed information on these patterns, and for the first time using some um, we were able to that that moved. Well, actually, this was key was because this was our introduction to surveillance, to saying people are not static, they move, and the people that in fact move differently. And this concept can sound basic, but it's not included in the way that this is prioritized for a strategy or control. Um, because when we prioritize some communities, but we don't prioritize the communities where they travel. So the communities where they travel may form a circuit that allow the importation of new cases. That's why we try to change the scope, static scope, and to select these communities to a wider scope in which they include the index community and all the communities that, where there is mobilization. And finally, to close, this is the last study of this project. We were able to quantify the effect of human mobilization in malaria transmission. And here we follow people for 2 months and we took samples every week. We had a team that was very empathic with the population, so they can give us blood samples every week to be able to do this calculation. We define movement patterns, and we can get into detail. And we were able to find what are those mobilization metrics that in a causal manner they generate greater risk of malaria in this period of follow-up. We know that the trade, highly trained areas as Masan are characteristics that favor the transmission of malaria. I'm going to take 2 minutes and then I'll leave some time for questions. But taking our elimination route, and I'm going to speak about what it comes in our lab. We have two projects to strengthen and to know if we are reaching our elimination phase. The first one is a project with London School called Freedom from Infection, and it is a probabilistic method to determine if um, if these report zero cases means that there are actually zero cases in the community, because you can imagine all the challenges that exist to reflect the data of the community in our system. For example, if a person has malaria in the community, they should feel bad enough to go to a health center, and then we have a probability. Second, when we go to the center, uh, the center needs to be open and to have available staff. That is another challenge, another probability. And we need the expertise based on symptoms to understand what is malaria and order a malaria test. There is another probability. And we have this one, and to avoid false positive and false negatives that can affect our detection of the parasite. So between the case and surveillance systems, there are a series of challenges.
Model these challenges or odds to know with a certain degree of confidence if we have interrupted the transmission of malaria in these areas. This is what probabilities are about, to be free of an infection. And we can see it looks more or less like this. The values that are on the bottom part are, or for example, 0.5, 0.6. These are moments in which our health systems do not have enough evidence to confirm that there is no transmission within the community. We know that there is no transmission because we have 0 cases in our report system, but is not enough confidence to ensure that there is no local transmission within the communities. And so in time, if this is a sustainable interruption or not, this is until we have a probability of 1, but we have a lot of different factors with ups and downs. And just the last one, so I don't run out of time, we have these. And this is going to be generating digital infrastructure. And I have been speaking about this since the beginning of the presentation, and it's how infectious diseases have a link to this infrastructure. Even though we know this and we have more or less an approximate idea in the lab and everything, and we've been able to develop, and you don't know how difficult it is to speak about different databases, interoperability of data, and others, which are experts. We're going to be talking about this in the next session. But this interoperability between between the field and health field, we're going to be ready. And so what we're doing here, what we're trying to do is trying to create a digital infrastructure that is going to allow us to harmonize these things. This is a sort of meeting point between both of these fields so that we can make environmental information available so that we can understand infectious diseases in Latin America. Now, this is a project that we had been working on in the 4 countries. We have the 4 intervention packs: Brazil, Peru, Colombia, Dominican Republic, and these represent 4 focal points of climate change. And this is towards the design of architecture, as audit data, integration, data administration, has concept tests, etc. And well, because of time, I can't say much more, but we can speak of this further along if any of you are interested in adding or understanding these initiatives differently. And Well, we just wanted to thank basically all of the institutions that have become or have been part of this. University of London, California, San Diego, University, uh, Lima, and Climate Change Center, Climate and Change, and Drexler University as well, the Health Center. I'm going to leave my email and my social media if you want to uh, be in contact. And again, this requires, it's very open, and we have to listen to each other to be able to continue moving forward in this. Perhaps this is something during the pandemic, and there were moments in which we did not have this. So I'd be more than happy to answer any questions that may come up. Thank you very much, Dr. Gabriel Carrasco. Thank you very much for your excellent presentation and having covered this from the new dynamic point of view with the in regards with the transmittable diseases, highly important transmittable diseases in Latin America, particularly in Latin American countries. So, I mean, these are things that have reminded us of certain things that are central to the experience that we have in the intervention and work that we're doing for the control of malaria, which was the Panafra project. And so we have added something very important in regards to how a new strategy can cover the control of malaria without insecticides, in which we had four countries that were participating, four Andean countries: Venezuela, Colombia, Ecuador, and Peru. Just to remind you that, well, without further ado, we were present in these processes for the preparation of the project. And, well, we got together and we gathered the intentions and good disposition of the Ministry of Health so that we can create a project that was channeled through the National Health Organization. And then we were able to get an approval in year 2004. So this work was intense, and it allowed us to have two very important aspects within this. The first one was to cover new strategies where we are no longer using insecticide as the main element for the control, as you've mentioned, that contaminates the environment less, that it has a very high cost of intervention, that there isn't the possibility of eliminating hydrographic basins, as you will have been able to show us through the use of technology and others. And we have the variability that there is, and that allows us to find the presence of large outbreaks of Plasmodium oxytero that had gone over the indicators for the transmission, the prevalent transmission, as we had known, we had seen by Plasmodium vivax. We had this curve there, and it was truly intense because it generated more cases that were lethal cases and more transmittability. And we also appreciate identification through the work that you've carried out for establishing that Paredes Darwin, and one of the most important transmitters of the disease, which is very resistant, very powerful. It's a tank from the Amazon that allowed for this constant transmission in the populations that are the native populations in the Amazon basin. It is important to notice or to point out this control project for malaria in border areas of the Andean region. There was a communitarian focus, and this gave us the tools that all of the health ministries actually needed. And these tools were fundamental to be able to have the possibility of having a control of the illness in a local space where the promoters, health promoters, and others identified by the communities had tools and instruments to be able to detect and immediately respond to the illness and also give adequate treatment and timely treatment. And as you've been able to explain, distances, for example, to be able to make classic control for malaria were impossible to be able to control, given that, I mean, you have told us that distances were truly large, up to 3 days or more. Definitely in the Salud network, not having the possibility of employing or being able to get samples brings us to the possibility of perhaps even taking over a month to be able to deliver everything that the patients need. And this is through projects, and this is where we have solved giving microscopes or protective mesh, insecticides to be able to protect children, and mosquito nets, giving treatment to the patients. And this is through a diagnosis and other tables, and having the possibility of multiplying the networks. And these, which have been pointed out magnificently well through the study that you have shown us. Now, the next aspect that we believe is very important, and you've spoken of this, and it's related to the magnitude of these things that goes over the possibility of being able to make a sort of intervention unless we completely change the strategy. Now, this strategy has given us significant results, and this then again becomes relevant through the use of technologies, as you have stated, and the use of drones and the use of observation in general and the information of the hydrographic registry through satellite imaging. And we have the interventions in points and focal points, which are risk points with everything. And this, for us, is very satisfying to be able to get to know. And we hope that you can ask any questions that you have now so that we can get an answer. If you have any questions, please go ahead. Dr. Carrasco, our jungle has, will always have characteristics which are very special for controlling these things. It's completely different now because the factors that favor the reproduction of the vectors of transmittable diseases is very high. Now, you have had, within this study, you had the possibility of identifying temperature changes and increments of transmission. Thank you very much. Thank you for the question. And it's fascinating, really, because in the studies that we've carried out and that are corroborated by some recent studies in Brazil and Venezuela, what we are observing in the Amazon basin is that it's becoming warmer and drier. And this is a change which is macro regional. As we have seen in Latin America, the largest amount of transmission of malaria happens in this area. But even within Loreto, there are areas that are already under this. So what is the largest risk? Well, here we have information is characterized by a very large hydrological abundance. And what does this mean? That even if we are temporarily forming bodies of water or areas where there is a breeding area for mosquitoes, there is Moscow, like a cleaning area. So this means that it rains so much that it starts raining, and then the water bodies begin. We have the mosquitoes, and it rains so much that water starts creating a current, and those mosquito breeders start proliferating because of the abundance of water. Now, given that we have these new trajectories, they're warmer or drier, these washout periods are no longer going to be as frequent. That means that there are going to be certain areas where perhaps before there was no active transmission of malaria, and now there's going to begin to be transmission of malaria. So what actions should we be taking? And here is perhaps where we can have some models for the prediction to be able to make a forecasting for these interannual meetings. And this is where they begin to be more relevant. And they can't have a relevance here and not have a counterpart in operationalization of these activities. And so we are now at a critical point, I believe. The actions that we can be taking to climate change in general are more important than ever, and we have less time to implement it. Thank you. In the Americas, there are satellites. I don't know of Andean countries that perhaps now have the current possibility of having satellite imagery that will allow us to cover more information. Costs have gone down significantly. Doctor, for your study, what would you recommend in regards to the use of these images? And how do we cover the institutional response on behalf of the Ministry of Health to be able to create stages or having information, online information quickly so that we can identify this information? Thank you.
Excelente pregunta.
Excellent question. Well, the use of these technologies has been implemented very quickly in the last few years in Latin America. What we haven't implemented with the same speed is the access to this information. For example, Perusat is managed by the Airspace Agency of Peru, and we have had no problems to the access of this information given that it is academic institution, but it is very restricted. It's restricted the type of access that we get to this information. What would my recommendation be? And this is in part why we've begun with this project, is that there is no middle point where information from different fields would be integrated, or we can add these. And so the integration on this in this case from different fields depends mainly because of the effort, academic effort, or very isolated efforts from public institutions. Now, what should we do, or what, in my opinion, do I believe that we should do? Is that this type of uh, stakeholders in different ministries, this is basically almost always happening in moments in which there's an emergency, when there is an earthquake, when there's a flood, but it doesn't happen for systematic control or these surveying systems for different illnesses or health events. I believe that this should be the first step, to have a dialogue table, which is a work group basically that is intersectorial, that is going to allow us to finally be able to take advantage of these multiple resources, but also allow others to speak. And so this interoperability of information is not just dialogues. It's a process that can last many years. It can be very complex, even though in these investigations, in these academic investigations, we can only see the final results. But within our workflow, the harmonization of data can be between 50 and 60% of our time allocation. And so just beginning by having this point in which we are meeting, converging these activities so that we can have conversations about this without needing to have an academia stakeholder, this would definitely power any sort of activity that we can carry out in both sectors. Thank you very much, Dr. Gabriel Carrasco, the Andean Organization for Health. We appreciate your time and effort and having participated in this significant event that is carried out after 10 years of the suspension, but that we now have had important, significant energy. And we're going to take into account that we have recommendations that have emanated from your presentation. Thank you very much, Doctor. Thank you for the invitation again. Okay. Okay, so now, right after, we're going to be inviting Dr. Rafael Lozano. Now, he is the Health System Director for the Institute of Health Metric and Evaluation, and it is IHME. And he's currently a professor of sciences to be able to measure health in the School of the University of Washington, and System Director in the Institute for the Metrics and Evaluation of Health, IHME. Now, before this, he was director of the Center of Investigation in Health Systems in the National Public Health System of Mexico since 2013 to 2017, and General Director of Information, Health Information of the Health Directorates of Mexico 2001 to 2007. Apart from this, he worked in the WHO from 98 to 2001 in the Health Information Center. Now, since 2019, he is part of the scientific council that coordinates the studies of the world load of this illness. Currently co-president of reference group of the health statistics of the OMS or the WHO. The medical, he is a surgeon, the Autonomous Universities of Mexico, master's in social medication, and he has over 250 different papers published in scientific journals and also around 94 references, 94,000 references to his publications. In 2021, Mabe gave him the recognition of highly quoted investigator in his field on a world level. Welcome, Dr. Rafael Lozano. Yours is the floor.
Buenos días, ¿me pueden escuchar?
Good morning.
Muchas gracias, doctor
Well, thank
Bengolea,
you
por
very
esta
much, Dr.
introducción.
Bengolea, for your introduction.
Le agradezco mucho a la doctora
I
María del
really
Carmen
appreciate
Calle,
Dr. Maria del Carmen Calle,
secretaria ejecutiva del organismo
Executive
andino,
Secretariat of the Andean Organization
que me haya
for Health,
extendido esta
for her
invitación.
having
Y
just
también les agradezco
sent out
mucho
this
su
invitation. And I also
su
thank the organizing
flexibilidad.
group for their
Tuve un
flexibility.
problema
I
de
did have a
agenda.
problem,
Yo estaba
which was a
programado
part
para
of the
hablar
agenda. I was
de
programmed to speak
algo, pero ahora
yesterday
voy a hablar
about
de
something,
otra
and now I'm
cosa,
going to
pero
speak about something
conectado.
different.
Y si
But
me
now it's
permiten,
connected.
voy
And if
a
you allow
compartir
me, I'm
pantalla.
going to share my screen. Is that possible?
Adelante, doctor, tiene la
Go ahead,
posibilidad.
doctor. Yeah, of course.
A ver, ¿y la están viendo
Okay.
ya?
And can
Ahora
you
sí,
see it? Yes.
ok, la voy a poner en modo
Okay, I'm going to put it
presentación.
in presentation mode now.
Ok,
Okay.
ahora voy a quitar esto.
Now I'm
Perfecto.
going to remove this and then perfect. Okay, so
La sugerencia que me hace
the
el
suggestion that was
organizador
made
es hablar
by
de
the
las
organizer was to speak
experiencias
of the
para
experiences from the
combate
Institute
este tema
for
de la
the
salud en el
Evaluations and
contexto de la
Metrics for
pandemia de
Health within the
COVID-19.
pandemic
Me
context
pareció una
2019.
sugerencia muy
And I thought this
interesante,
was a very
sobre todo
interesting
porque estamos en
suggestion,
un
mainly
foro
because we are in
nacional
a
de salud pública
forum in which we are being more vigilant on
y la
health
importancia que
systems and the
esto tiene.
importance that this has.
Antes de
And
entrar a la
before
presentación,
going
quisiera
into
algunas
this
ideas
particular subject, I'd
generales.
like to give you some ideas because, truth be told,
El
there are
Instituto de
people that don't know
Vaccination,
about the
Research en
Institute
inglés.
and they have, well, the
Somos
acronym
una
in English,
organización
but we are an
independiente, estamos
organization
ubicados
which
en
is
la
an
Universidad
independent
de
organization.
Washington.
We are in the
Hace
University of
15
Washington.
años se fundó.
For over 15 years ago,
Ahora
this
somos el Departamento de
founding
Ciencias
members,
para
and
la
now
Medición
we
Médica
are
de la
just
Escuela de
completely
Medicina.
scientists to be able to
Somos
measure in the School
alrededor
of
de
Medicine.
500
We
personas,
are
de las
about
cuales
500 people, of
15%
which
somos
15%
profesores
are
investigadores. Uno de
investigative
los
professors. And this is one of the
assets, este es uno de las
assets,
cosas
the one of the
importantes.
things,
Tenemos
the
una capacidad de
important things.
computación
We have a
equivalente a
computing
algo así
process
como
which is the
1020
equivalent of
nuestro RAM es
31,000
de
computers, and our
240
RAM
terabytes
is 240
y
terabytes,
tenemos
and
datos 20
we have
gigabytes.
data
Esto
of
no voy a
about
meterles
20
equivalentes
kilobytes. I'm
porque
not going to go into equivalences because you already know about this much more than
yo
I
me
do.
quedé en el
I was
gigabyte.
left at
El
gigabytes.
GBD cuenta con una
So
red
GBD
de
has a network of over 8,000
152
collaborators
países
in
y tenemos
152
colaboraciones con
countries. We have a
organismos
very close
regionales,
collaboration with
con la
regional
OMS a nivel
uh,
Ginebra, con la OPS.
organization in
Y la HMI desde
WHO and
2010
Geneva. And since
acumula más de 2.000
2010, we've been
publicaciones de más de
accumulating over
250.
2,000
Nosotros,
publications.
como decía
And as we
el
had
doctor
said
Bengolea, en
by
2021
Dr.
tres
Vengolea in
investigadores
2021, three
reconocieron
investigators
entre el grupo
recognized
mejor
us
reputado del mundo.
amongst the ones that are
Visitan
most quoted
mucho
in the world.
nuestro
They
sitio
visit
y ustedes
our
pueden
site
ver
a
que
lot,
nuestra
and you
misión
can
es
see that our
amplia, nuestra
mission is
misión
very
es
broad.
entregar
It is to
información
deliver
relevante,
information that is
oportuna,
relevant,
científicamente basada en
opportunistic,
evidencia,
scientifically
con
based on
énfasis en
evidence,
el
emphasize mainly on the impact and also to be able to create a culture for science and to be more global. Now, why did we get involved in the analysis of this? Because of principle. It's based on the measure that we have so far, but also the request. We have the University of Washington, and we requested the prediction. And remember, in the United States, the pandemic came in to the country, and it came from China, and there was a communication that was 3 flights a day from China. It was impressive, really. It was communication was amazing, and there's a port which is very high transit for commerce, and the university, we were told, hey, can you help us to create a model to tell us when we're going to have a more massive event for this? And this is how the story started. We started with a very simple model, and little by little, we expanded it. We saw it with other states in the country as well. The first time HMN gave us a response of the need that we had in the country where we were placed, and then we started working on in Europe, in Latin American countries, and in the rest of the world. And currently, if you go online, you'll be able to see policy briefings or summaries, political summaries for all of the countries in the world, including the Andean areas and also for the regions of the OPS, which are, well, I'm going to be placing all of these at the end of the session. It's 30 months of experience. And in these 30 months, we learned a lot. We updated every day for about 30 weeks, and then every week, and then every month. And from a very simple model, a model that was trying to understand and how to predict using death, highest level of death, and then little by little, we started incorporating more. We were able to follow who is using people that are using. We have epidemic analysis, and also we began incorporating variables. And now I'm going to speak a little bit about what we have in 2022. All of the estimations, you can download these, and also the entire way from 2020 to 2022. And this is the typical curve that appears in our visualizations when we see the amount of deaths that are reported and in total. And we've also called this the excess or brutality. So we have a slight difference with the estimations of the OMS because, well, until 2022 at least, we were accumulating more than 15 million if these folks are related to COVID. Now, as the pandemic moved forward, it became a very trustworthy source of information, and we started getting consultations from many different areas of the country and the region. Europe, we were sending information to the regional offices of the WHO. We had reports that were optimized, and we had them used in the press conferences, for example. And this is based uniquely on data. We, what we are trying to find is to be able to measure the impact, to be able to suggest preliminary or very good measures, including social distancing, for example. Every day we have more and more data, but the most important thing is that we incorporate things that perhaps were not incorporated previously. And this is thanks to the emergence of big data and computing. So we brought structural data, we brought non-structural data, and then we also tried our preventive capabilities. And here we have this on this chart, for example, is differently. But people, we're not the only ones. It's good that we're not the only ones that are doing this type of analysis. As we have spoken, Dr. Chris Murray, which is part of the Institute and currently is a reduced group, but it was about 100 people, and we learned very much from this entire process. And I would like to clarify that what we do is predictions, basically. We do not make the reports. John Hopkins does reports every day, for example, or what countries do every day. They were not interested in building future scenarios. And then, well, while some of the predictions are comparable here, we have something that's very different, and this comes much closer to what's happening in reality. We evolved to be able to move in and have relevant knowledge that is something we can process. And this is a model, an original model that was designed for us being able to plan hospital capacities. And we were clear on the fact that for decision makers, they were more interested in the projections, and we were using this principle to project the future based on what it is that we're living and learning now to be able to modify the actions in the present. So, some questions have been evolving in time on what the needs of the hospital were and how to come out, how we can scale the distribution of vaccines, for example. And truth be told, the problem is when we mix technical and political agendas, because in this, politics are something that just ruins everything. And so that's when we incorporate the political interests on top of the scientific evidence. And what we can see here in the response is that there are very few that make estimations per country, even on a subnational level, for all of these components, as could be the use of masks, for example. And for 2022, this is already completely abandoned. And curiously enough, we can see that in Peru, in Bolivia, it is less abandoned, but the rest of the Andean areas are truly something that we have to look at. And Venezuela, for example, and in regards to vaccination, we have this great gap that is something that the entire world has presented in regards to the medium income, low income, and heavy income countries. And what we want to review, what we want to look at with you is how we're looking at this entire map. And I think more importantly, we have to imagine this idea of the fact that we do not work with a traditional vaccination model. We continue working with a emergency vaccination because we understood as a world community that even though we discriminate, we find the genome of the virus very quickly, we understood that we could not wait to have the results, the typical clinical essay results, if we wanted to be able to confront this. And I believe that we also incorporated a vaccination with DNA or RNA, which is a vaccination that had not been used before. Now, what happens with immunity and why haven't we seen this before? Because COVID truly changed the paradigm in many things. Now, this is the effectiveness of the vaccination in terms of getting the infection again. If we look at the small square on the right, which is in the moment in which we have zero, when we get the vaccine, there are two vaccines that are placed here based on the publications. Pfizer has an effectiveness of 90%. Moderna has 95%, AstraZeneca has 76, Johnson and Johnson 87. But what happens when time goes by? Well, we start losing this capacity. The cells, the T cells no longer remember everything that they have to remember. And so this then opens a space in which immunity escapes and there can be reinfection, even in people that are vaccinated. It happens in a different panorama when we look at severe illnesses. For severe illnesses, we have much higher effectiveness and we keep this effectiveness for much longer. Now, this type of chart, for example, for anti vaxxers, which are very frequent, I mean, they don't have the importance because, truth be told, this is a principle of just not including a certain amount of people that are going to be, or an agent that's going to be protecting you against severe contagion or death. And here we can see different modalities of vaccinations that were circulated in the world. We analyze them all because there is not evidence for everyone. And perhaps one of the most interesting things is how we have built this around the infection. We have this chart on the left, for example, and what we're looking at are the different types of variants. These ones that we have and those that are beginning with the epidemic, the alpha, beta, gamma, delta, etc. And as we know, it's a common knowledge, and that we're doing very well until the Omicron came up. Omicron really ruined all of the predictions and everything that we had been working on, and so it deserves a very particular understanding and coverage. And here, Omicron is really taking away from cross variants practically in every single one of the other variants, which is something that does not happen with our ancestral variants and alpha. And so we can also see that the fact that we are uh, getting the illness does bring down natural immunity or for the infection, and not as strongly in terms to any severe sort of infections. And all of this data that I'm presenting now, which are charts made by us in studies, not carried out by us, but these are other studies where we have metadata or meta-analysis of the information that has been published previously. Now, we're interested in measuring the infections, previous infections. For example, this is the case of a state in the United States, for example, where we have complete information. We have information of the daily cases. Here we can see the lines where they are seeing the different variants. We have information about hospitalizations and we have death toll. And you can see that our predictors, the index of vitality or the index of hospitalization and infection, they grow in terms of accumulation and also in terms of time. And it helps us very much to have measures of the consistency in which there would be cases or the infections, which is what we are predicting on the top, and the presence of just the surveys in a measure which we have been carrying out the surveys, then we were been able to be more consistent in our predictions. Now, what is the problem here is because not all of the countries have carried out surveys, and so we began to have generalizations that are not as correct as we would like. Now, I'm showing you the data to yesterday. And this is where we are currently at if we were to look at this estimation. And on the left side, for example, we have Peru, and this is, well, this is a small part, but this is Peru, where we don't have hospital registry, but we're very clear in time on what the wave was in Omicron and the different cases. And we see that on the right side, close to this chart, we have an increment because there is no consistent report, but we do see a rise in the amount of cases, but not in terms of what would be hospitalizations. Given that, for example, in Mexico, if we look at Mexico, the cases go up, hospitalizations go up. And so it was more or less 15%. And we were very clear on what the waves are in hospitalization and also in terms of death tolls. In some federations in Mexico, for example, are 32, and there are others present. And in this last period, what we would call the fifth wave is an increment that it goes over this amount. Now, another of the things that we did was to understand excess of mortality. I'm not going to go too far into detail on how we're measured this, and we're going to describe the results, but I would like you to look at, in terms of colors, what the countries are with highest level of mortality in the world between 2020 and 2021. And it's not necessarily too heavily linked to the reason of mortality and what's been reported. So if you look at practically Africa, Mexico, some states of the United States, all of the area are part of this area here. Brazil, for example, Eastern Europe, all of them have between 5 to 10% of 10 times, I'm sorry, higher mortality in excess than previously reported. And this is linked to the capacity of the mentions of each one of these countries and the response. The specific attributes of Omicron, well, first of all, it taught us that the speed of invasion is impressively quick. We end with this idea of ancestral viruses. We ended with the idea of the previous variants, and Omicron in 15 days had already flooded the world. It was so quick how it was transmitted, and the double of the speed in which we had expected it from Delta. And on the other hand, the activities of the vaccination, as you can see, this complex board, different vaccinations on the left side and different stays of severe infections for the different variants. And so, truth be told, we see that if, for example, we take Moderna, that Moderna, in terms of the ancestral variant, had 97% effectiveness at the beginning for severe illness and also 92 for infection. And if you continue on this line, you can see only 90s till we reach Omicron, where the effectivity is of about 73% and 48% for the infection. And so this is where this effectiveness after the dose of the vaccination, we see it goes down in time in the previous chart. And we can see that it goes down even quicker when we are in Omicron. And so that's where specificity from Omicron, we lose that quickly. And apart from that, it makes it so that we lose the effectivity against other variants. And so we had this and we lost the economic opportunities or the opportunities in general. But you can see here in Omicron per se, but all of the variants that we have been looking at with this version of SARS. And so it is highly infectious, several multiples of Delta. The cases are non symptomatic. And so there are just this idea, this being derived from a South African essay with the prevalence, which is 31% at the beginning of December of last year, as the detection of hospitalization in patients which were without symptoms. And so we began noticing the current statistics, which in this case is more than these cases, it's more incidental that are associated to other types of illnesses, but that people are already going to get cared for. We have the beginnings of the hospitalizations and medical care, and a survey that was carried out in the United States, the prevalence of this in some of the regions at the end of December. And so we saw a reduction of Omicron in the hospitalizations, mortality rates went down, immunological, and this made it so that these people that were vaccinated got reinfected, or those that were infected get infected again. And why are we interested in predictions? It's because of this. It's because for a decision maker, it is not important to go day by day. It is that we have to anticipate. And so understanding that Omicron is then extended into China, and then we find put China into a flatness, and then we go into something as explained to some Shanghai, Huning, and one of the central problems, one of the measures is different. It's different from what China is doing in the rest of the world, and so the way it is being affected further than what is done in China. We have the control measures in the rest of the world, and it's when they are submitting to all of the population. We have complete isolation. Its maximum point so far is 20 days after this exponential rise, and we see that we have these waves, these subvariants, and these are the A1, for example, and we have 20 days. And that is why we dare to say, well, I mean, this is part of what we're looking at. And this is, for example, once we have the concentration of the wave. And for example, you can see the predictions that we make for the infections and cases. If I mean, we're placing the surveys here. We have, I apologize for everyone, all of the participants. I can't put all the countries here, but you can see the order of magnitude. And then we have the infection. We have 10 times more infections. And I believe that in Peru, we made large efforts to be able to carry out these tests. In the scenario, the green scenario is where we have the references. And the scenario, the purple scenario, is the increments in the use of masks. And we can see that it has a more of a protective effect, which is necessary. But then we are now going into a process in which we can do something about this. And so the death toll is also different. So we have the devastating effects in the first wave, and then we have higher levels than that with Delta, and much less.
in Omicron than in others. Now, the new variants, of course, it is very probable for others to come up. We have more than the lineage of Omicron, and this is where we can also look at perhaps we have others. We have less of a social distancing, and this is also bringing us problems because we have the increment of the number of cases that we have in the United States, Mexico, and other countries. The combination of different levels, this is improving immunity and vaccination, continuous vaccination in every moment in which we have efforts and we already have medications, for example, and the knowledge, in fact, that people can uh, or should be using these masks. And there is no doubt, and I know that in this case, we now have a presentation of an idea, and it is being able to manage this illness well. What is it that we learned? uh, Things that we have applied in this study. We have different illnesses in COVID, and this is now occupying a preponderant level of analysis. This is part of the world map. The percentage of deaths because of COVID in 2021, which means in Bolivia, for example, half of the death toll. uh, Peru 41%. In Mexico we have 34%, and I don't remember any other illness that had accumulated this number of people that were catching it. And so this had very significant levels. For example, outside of South Africa, well, not even Africa or South Africa, India and others in Botswana, we had these very similar levels to that of the Andean region, and well, Nicaragua and other countries as well. And so this is a schematic, or this a chart. I know that it's just Mexico, but we're presenting the lists of the priorities of the different indicators. If we were to place the main death, main reasons for death, then we have this. If we are to place the years that we have, COVID is one of the main reasons that this has gone down. And of course, violence has gone up. Now, if we have looked at the years lived with disabilities, we have 12. And then here, if we are combining premature death and disability, then this is one of the main causes that we have a reduction of healthy lifetime in Mexico. And if we look at it by sex, this, well, mainly it's in women, 21% of the entire load, 22% in women. It's one of every five is lost. And well, we have this, and this is a certain amount lost in women, and it is one out of every four. Now, this is the first cause. Here, we can see the composition of causes. This is preliminary data, and in favor of well supervising these authors because we are now fine tuning the last few details. Now, if we look at this per groups, those that are less than five, this is cause number 10. So between 5 and 14 and 6, 15 to 49, this is where the violence is in Mexico, for example. This is more important. And here we can see from 50 to 69, we have these amounts. And so COVID then goes into these health priorities in Mexico in a very important way. And we can see that this is the main cause for deaths. And we can see this within the access, this higher access. And we have the first name, we have the states of the country, and what would be the main causes of lost years. And naturally, in Mexico, we have 15, we have the order, and there is no doubt that we have systemic, and we have the second or third, we have interpersonal violence, which is the second one, and then we have the, well, I believe it's the fourth or fifth. Yesterday, curiously enough, we have estimations in the United Nations 2022, and it occurred to me to present the life expectancy in the fields of the United Nations for some countries that are selected in the orange color, which is where the world is. And here we can see we have a certain amount, for example, the ONU in the 2019, this drops. It drops and it recovers again to 2023. Now, this is the column, which is the orange column, the line, that's the orange line. In the United States, we can see the top part, we have a better life expectancy, and we have the 3 years and we lose 1 year. And curiously enough, we recover and it continues growing. That is what we see. It catches my attention, the fact that it is this magical here. And magical is our realism, being able to promote this with Garcia Marquez or everything that we have. It is truly magical, and this is where we are debating and we are talking every day. And so we lose the life expectancy in Peru, Bolivia, and others, and we avoid the fall for several years. And I don't know why the United Nations says 2 years in Mexico and is better than what it was at in 19. So it is when Bolivia was choosing for this, and we had 2 or 3 years or more. And this data is now official data, and you can download this, you can analyze it. But here we have the impact of what we have for COVID, for example, in the period of 2020, 2030. And so, what is the status of the global data? Here we're going a little bit further into well, what we had from yesterday, but to our conditioning or our judgment. Data is very superficial, the data that we have. And I apologize for having said this. It is current data, but it is based on a model that has not truly gathered the importance of this illness. And so we this is not good enough for us to have the questions. We have to respond, and we need responses. And so, in the consequence, these decisions, when we search for global impact, they are then derived by context and the information that we have in effectiveness. We have, for example, in Israel. Israel, there's a lab in 2021, and that's where all the data was coming from. The UK was working very strongly in trying to gather information, the presence of the variants in South Africa. Here, this is something that did very well. We had the rise of the cases of Omicron, and here we had certain recommendations that perhaps could have been different. And it is very difficult for the countries to generate a version that will allow us to recover all of the data that's needed, because of course there are different priorities. We have more of an importance to data than medical attention, and in this competency we have the resources, which is finite. And this is something that is generating the attention and of course the loss of the trust of the population in the health systems in the world, in particular our region. So it is important to point out the impact. This is a question that we ask ourselves. Is it clear for us, for the audience? Is this clear for us, or are we describing the situation? It is it important to establish a collaboration, but also how we're going to be contributing with the generation of a group of data that is related to the mentioning of health, and what elements are necessary to recognize when we have these databases that we just currently have, and to understand the biases, what the global levels are, what the points are for the comparison, and are we poor in data but rich in questions, and also just to open up a dialogue. And this is a forum for us to be able to talk about the status of the information in the region and in the world. So we have to prepare for the next pandemic. The goal is to show the values of the investigation and what it is that we're going to be doing for the data consumption. And this is fundamental in this sense because we have changes, the theory of change, and this is where we're showing collective gaps in data. This is where we can respond to data, or we can respond to change, and we have new information and justifiable information here. What catches my attention here is that COVID, for example, we were reporting everything that was happening every day, and we were able to look at the number of people that were coming in and coming out, and we had differences. But if I was allowed to do the same thing in schematics, here we see the disappearance of certain things where this could be done, and it was shown that it could be done. But why aren't we doing this with the rest of illnesses? This is not a trivial matter, but it is also not the kind of challenge that we can solve. And so we are working together to be able to solve certain things and the threats that we can find. And we are clear in the fact that we are in a sanitation crisis, a sanitary crisis, but also we're trying to find independent authorities, and they're centered basically on being able to give different kinds of evaluations and threats to health, for example. And because of this, I'd like to point out that we are establishing a very significant efforts to be able to become part of a regional consortium against health issues. And this consortium, given that it is mutual, it is a collaboration of the organizations, multidisciplinary organizations and sciences that are going to be separated by the political area and the interests of the government. And what they're going to try and do is give us data analysis to be able to improve with the information and the institutions, multilateral institutions. And so the consortium is something that we're looking at in two different levels. One side monitoring vulnerabilities, and then another looking at the decision making processes, vulnerabilities in the health system. The health system, well, I can't say more dramatically, really. I mean, we do understand that there are many things that are related to COVID, vulnerabilities in the environment and others. And these are things that we find that are articulated or not. And on the other hand, with this help in these cases is building databases mainly to be able to improve our risk analysis. And these are things that are a serious problem in all the evaluations, and they're not opportunistic in these risks. And we left to sort of a red light, green light in which we could go out or we couldn't go out, and we should have a response to this. And I just wanted to finish my presentation by saying, look, we are an agency or an institution, educational institution, but we also open our products as public goods. Here we have the growth, and we have several different resources. We have different intentions here for COVID. And as academics, we have to continue moving forward, and we have these high impacts. And I can say that all of these publications, everything that we have from longer COVID, but it has generated impacts in the review of this subject in many different things within the community. Now, I don't want to finish my presentation without having said that, well, when we talk about sciences to measure health, many people get carried away because they say, like, for example, with the computers or the capacities and data science, then we're going to be able to do practically everything. And I get the impression that there is sort of this bubbly feeling because of the amount pages or leaves from the larger trees, it give us the impression that that's where the solution is. And if you look at the right side, one of the most important things so far is what is above this, and it is the roots. And it's the reason that we're working on this and we have these health issues is because we are creating the roots of the importance to be able to reach the decision making, even if it is not as fluorescent as we have on the left side, which makes it so that we can see or we have the appearance of other things. Now, I'm going to stop here and I'm going to leave you with these lines, and I am available if you have any comments or questions that you'd like to make. Thank you very much, Doctor. Go ahead, please.
Excelente, doctor Rafael Lozano. Usted nos ha hecho un viaje extremadamente interesante en
Thank you,
cuanto a
Dr.
todo lo
Rafael.
que
You
hemos
have spoken
Excellent,
about the
Dr. Lozano.
value
You've made a very
of
good
the
trip in this value
metrics,
metrics from the
starting
beginning.
to recognize
After
that your
recognizing that this
institution
institute,
is
Instituto de
the
Ética y Evaluación de la
metrics
Salud
this Institute for Metrics and the Evaluation for
tiene
Health,
la
and
posibilidad de
this
poder
has the
asistir
possibility for
muchas
having
veces a
been able,
instituciones y organismos de salud que a
institutions and
veces
health
and
organizations.
presentan
that allows to
¿verdad?
present the result of the assessment of the
Han
pandemic.
insistido
We
ustedes
have
en
insisted
la calidad de la
um,
información que debemos adoptar para
in
tener
the quality of
los
information,
elementos
and we
de
are covering three
control
main elements in the final result for
y
control.
algunos elementos
One of the elements
relacionados con la
is
calidad.
related to the quality of the
El
information.
punto siguiente, la
The
evaluación
next
de
step,
riesgo y
assessment, risk
finalmente la toma de
assessment,
decisión
and
consensuada.
finally,
El
decision
valor de
making.
una información
The value of
usada
information that
en el
could
momento
be
y en el
used
tiempo
at the
para
time
promover cambios
to
significativos
make
desde el punto
changes
A hacia
in
acá,
the
a
intervention.
través
This
de
has been
diferentes
highlighted
gráficas
by
que nos ha
different
permitido conocer la
graphics that
proyección
have
del
allowed us
proceso
to know
a
the
futuro y
projection of the
finalmente
process and to the
demostrarnos
future, and
que
to
el problema
demonstrate
aún no
that
termina.
the problem
Un
hasn't
elemento
finished.
sustancial ya
A
desagregado en
substantial
su
element
presentación
disaggregating
la
your
relación
presentation is in the
algunos
relation
indicadores
between
como
some
la
indicators
mortalidad por
as
hospitalización
morbidity,
y la mortalidad por
hospitalization, and death,
COVID
and an
y
important and fundamental point is to support the effectiveness of the vaccine. They have shown us, the countries have used these projections, and this has generated a data that maybe not we all know the impact of the Omicron a variant that has had a transmissibility, high transmissibility, and that overpassed the one that we had, which was the Delta variant. This Omicron is breaking uh, and any uh, standards, and is and here we still have, and through their analysis, and well, still don't have a final projection. It's important to highlight the call that you make to improve information, that the scheme that we are using to present information needs to have a substantial change, and not only in the sector, health sector, but other institutions that are relevant and highly important, and that promote the creation of a consortium for future emergencies. Dr. Rafael, it has been a brilliant presentation. We appreciate your
seguir contando con
presentation, and we
a través
hope to continue
del
uh,
trabajo que pudieran hacer
working with
con
you.
los países andinos. Muchas gracias,
Thank
doctor
you
Lozano.
very much, Dr. Lozano.
Bien, estimados doctores,
Now, dear
queríamos
guests,
seguir
we
que
hope
pudieran
that
hacerlo con
in the
nosotros
questions, we hope that
y
questions that you could do
mientras
to the
vamos
doctor, and in the
preparando
meantime,
esas preguntas, quisiera hacerle una pregunta.
I would like to make you a question, doctor.
La variante Omicron
The Omicron
presenta
variant has presented with
bastante de preocupación,
a
pero
variant of concern, but at the
está
same
generando
time
escenarios
is
alarmantes
generating
que nos preocupan a los
sub-variants that are
países
being monitored
OPS
by
y
the
el grupo de
OPS,
científicos.
OMS, and a group of
Eh,
scientists.
una de las variantes,
One of the important variants is
la
the
4 y la
BA4 and
BA5.
BA5.
Eh, ¿Nos puede decir
Could you tell
cuáles
us
son
what are
las proyecciones que se
the
pueden dar con
projections
respecto a
for
este
this
país de
variants in the
Latinoamérica?
countries of the Americas and other
Muchas
countries
gracias.
of the region?
Con mucho gusto,
Yes,
doctor Bengolea. En nuestra región,
in our region,
digamos, de todo el continente,
um,
la
in
modalidad
this
variante
continent,
BA4
the
y
BA4,
BA5
BA5,
están
BA6
presentes
variants are present
prácticamente en el
in
hemisferio norte,
the northern
eh,
hemisphere,
con menor cuantificación en Centroamérica, pero
with less concentrations
llevando
in
incrementos
Latin America, but at an important
de una
increase, even though
muestra muy
it
grande
is not
y
a big
representativa
sample,
de
it's
estos
still
mismos países.
representative in the
No
case of Mexico and the
tenemos
United
la
States. We do not
misma
have the
información
same
por parte
information
de
um,
los
in the
países del
case
hemisferio
of
norte.
the countries
Veo
of
que
the
entre los
southern
presentes
hemisphere.
está gente
I
del
know that
CDC,
among you, among us, we have people
seguramente
from the
pueden hacer
CDC that
mediciones
are doing
más
measurements that
específicas,
are more specific,
pero
but
la información que
the
nosotros tenemos
information that
es
we
que
have
no ha
is that
llegado
still
al hemisferio sur
hasn't reached
con ese
the
tema.
southern hemisphere,
Otros
with the
estados de
exception of
Brasil
Brazil. Some
tienen,
states in Brazil do have
esas variantes. Ahora, ¿cuál
these
es el problema de esta
variables.
variante?
Now, what
El
is
escape de
the
inmunidad.
problem?
El escape
The
de inmunidad es muy
immunity
favorable
escape,
a la
which
población.
leaves population
Afortunadamente,
in a vulnerable
afortunadamente los
um,
países, los gobiernos de los
status.
países tenemos
Um,
niveles de vacunación
we
más
still
altos que
have
otras
vaccination levels that
si
are
llega a infectar
acceptable,
a
but if
personas
we
no vacunadas
infect
en
a
la playa,
person that is not
vemos
does
casos
not have a vaccine, we
gravísimos
see extreme
graves
cases of meningitis
con ingresos
and
salas de terapia intensiva
and
grave.
and
Y eso no
taken to
descarta la posibilidad de
UCI,
desarrollo de
and
directas por COVID.
that might cause deaths because of COVID.
Muy gentil, doctor.
Thank you.
Mientras nos llegan las
After
preguntas,
that,
Peru,
we're waiting for the
Ha sido
questions,
calificado
and Peru has been
del mundo como
qualified as the country that had the highest number of mortality. Uh,
El estudio que han hecho ustedes de su proyección me parece
so
muy
I
interesante
think your prediction is
porque
super
advierte de
interesting from the point of view of
y este
excess of
trabajo que
mortality.
ustedes
This work
iniciaron para poder
is
tener una
basic
idea
to
de qué
have
pasó
an
en aquellos
idea of
países
what
donde se
happened in those
tenía mayor
countries that
mortalidad,
says that
tasas de
have
mortalidad, pero sin
the
embargo,
highest
se ha
numbers,
configurado
but we
realmente un
have
proceso para
configured a process,
desarrollar y que nos da una
and this
idea de la
gives
realidad.
us
¿Cómo sería
an
lucida
idea of
la COVID? ¿Cómo
reality.
fue ampliamente
Could you
estimado todo esto?
expand on that,
Sí,
doctor?
con mucho gusto, doctor Bengolea.
Yes,
Mire,
Dr. Bengolea.
en primer lugar,
Well,
hay
there
algo
are
que destacar.
first of all,
Muchos
there are
están
places that
preocupados de si
we
estamos
don't want to
hablando
talk about, that
de
we are talking about
resultados paserios, pero en
the
el caso de COVID,
American Cup
Perú no es
is
el
good, but in the
foco de
case of COVID,
mortalidad,
no. Peru is not the
porque,
country with the highest
digamos,
mortality.
si lo medimos en absoluto, son los
If
países
we
más
measured it in absolute,
importantes. Si lo
so
medimos en función de la población, hay
we can
países de
measure it
mayor
in terms of
mortalidad,
population. There are
pero
countries that with
Perú
highest
está dentro
mortality,
de
but
esos
Peru is among
países o
that
quizás de los
countries,
países
maybe 10
con una tasa de
countries
mortalidad
with
más
the
alta
highest
de la región.
mortality rates.
En primer lugar. En segundo lugar,
And in the
es
second place,
difícil hacer estos análisis si
it's
no
difficult to do this analysis if we don't have access
las bases de datos
um,
de causa
to
múltiple.
the
Yo
multiple
creo que
costs.
aprendimos mucho a
I
hacer
think we
estudios,
learned a lot
hicimos mucho
on,
el uso de
and
laboratorio,
we
se hicieron pocos
use lab
diagnósticos in
testing,
laboratorio de COVID, pero en realidad sí
but
tenemos muchos
we still
falsos
have
negativos. Y ahí es
a lot
donde
of false
entra
negatives,
la
and that's where we
utilización de la
have
realidad.
the
Y para
analysis.
eso,
Um,
en nuestras bases de datos
in
igual
our
hacemos una búsqueda
databases, and
intencional y
believe me, we do
agresiva.
an intentional
Tenemos alrededor de
search.
22
We
países
don't have
que hayan reportado
uh,
mortalidad de
22
2020.
countries that have reported the
Los
2020
modelos
mortality.
están
The
basados en esos
models are based
países.
on those few countries.
El retraso que hay, sí
The
sabemos que hay mortalidad
delay,
por la dificultad que tiene, pero por
we
ejemplo,
understand
Perú
it,
ya
but
publicó sus datos de
Peru has already
2021,
published their data for
pero
2021,
otros países no.
but
Brasil
other
ya lo
countries
publicó
haven't.
también,
Brazil has
pero otros países no.
presented this,
Pero publican los datos
and
con la
again,
causa
this they
básica,
published
no con la
the
causa
data with
múltiple.
the
Entonces,
basic
sí nos interesa
cost and not the
llegar a nuestras
multiple
conclusiones en
costs.
cuanto a
So we
estimación para
want
poder,
to
justamente
reach
para entender mejor la población y
a
poder
level
intervenir
that
cuando
allows
es
us to
necesario.
understand this better to do
Todas
more
las causas
prevention, but we are
constituyen
still in a
conocimiento, doctor
phase
Bengolea.
of knowledge collection.
Gracias, estimado doctor
Thank you
Rafael.
very much.
Doctora María del Carmen, si tuviera alguna consulta
Dr.
final
Maria
para
Carmen.
Rafael o comentario.
Bueno, fascinante la
Well,
presentación.
this is a great forum, really. A lot of information, a lot of appreciation of different places, and I believe that that is something very important. Since yesterday, we can see from the academia, from the civil society, in the institutions, um, the most recognized institutions in surveillance and public health. I think this has been a very good closure because what Dr. Lozano has presented is super interesting. It seems that, well, it not it seems, I think we have to do things always better, and maybe on the search for data, better data, and with the idea that this data is useful, that it becomes information and we can use it for decision making. I think I agree with Dr. Lozano that we have the politics and everything that you progressed from the technical point of view might not be as optimal. But I again have the concern about mortality. Um, Peru was one of the main countries that proposed so many variables. And well, we launched into the first position in our meetings. The question for Lucho was how you are or others are measuring, because to do comparisons, we should have the same variables, and I have to say that they aren't. Therefore, we can see these differences. The institute where Dr. Lozano works is speaking about a level, a higher level of mortality, and the OMS is also recognizing that. At the end of the year, I think they are going to
en el camino se han hecho
issue that
comparaciones.
information, but in the way there have been comparisons with different variables. So what happens, there's excess that is a very important point when Peru took the opportunity. Well, we didn't receive much echo about it. So well, my comment is that we need to compare things, and I don't think this happened. That's my personal opinion, because when we we have meetings 2 times a week, we cover these subjects, and we check uh, data for our countries, and I'm very demanding. I always say, Dr. Regalea, what are the variables? Have we measured this? How has this been done? Because it is not good to compare things that are different. Because if I define and another one defines another way in the way of the comparison, I don't think it was valid. I only wanted to mention that. What do you say, Dr. Lozano?
Bueno, primero le agradezco
First of all,
mucho,
thanking you for
doctora de la calle, la invitación.
your invitation, your comment. Well, invites me to react in 2 ways. The first one is that we should not lose the opportunity of preparing for the next pandemic after what happened and with what happened to us. We cannot go back to zero as it happened in many places. And that's why the proposal of generating a consortium with this independent groups. And again, for example, Dr. Murray commissioned this, and we can have a more detailed discussion. Now, the second, the comparison, well, we measure comparing by comparison. And when we compare, I always tell my students, sometimes you compare um, uh, against you in time to see if you have improved. Sometimes you compare with your peers, and that's where we started the conversation of what is a peer. Is it a geographical? Is it economic? What defines that peer is the question. And finally, the hardest comparison is when you compare yourself with where you should be. And that, if you have that capacity, if you have that human capital, why you were so far away from where should be. And that is not a comparison either in time or a comparison among peers. But excuse me for the expression, it's like when you look at your mirror and you say how much I have invested in education and look where I am. Uh, uh, or the other way, or look at how good you're doing. Eh, So it is against you. So when we adjust the socioeconomic conditions or demographic conditions, Peru, and we see and other countries of the Andean area, we see where they should be, is where we see the comparison, a more severe comparison, and that's where we are in, realize we're in a bad position. I wanted to extend an invitation. Now that we have the results of GBT 2020, let's try together to make a report of the countries extracting the data and presenting these tables that are very useful for decision makers with a very simple variables. And so that is how I would react to your comment. We will do it, and we will speak later to be able to do this. I think it's very interesting because the idea is to improve, and the Andean organization has to contribute to the health and of the 6 countries, and we know that the evidence um, are very important for decision making. We have, well, we know that when we don't have the right data at the right time, we can take decisions that are not the best. And now this pandemic is a breaking point, is a before and after. We cannot go back, especially in a region that is unequal and a region with so many differences. We cannot go back to the same. So we will be working on that. Thank you, Lucho.
Muy amable, doctor.
Thank you very much, Dr. Lozano. Thank you very much for your presentation. And we will continue speaking. Well, to all of you, I would like to tell you that in this time, we have wrapped up the first section for this meeting. This first moment consisted in sharing international information of institutions and organizations of technical cooperation and organizations that are related to information, to response and epidemiological response.
el análisis que han hecho instituciones públicas y
And
privadas y que nos brindan todo un panorama nuevo para enfrentar la
and a
siguiente situación.
new
Vamos a entrar
panorama.
en un
So
punto
we
muy
will
importante que ya
go
hablamos
to a very important
de
moment
cooperación entre los
for
países andinos
discussion between
y
the
vamos
Andean countries,
a
and
cerrar este
we wanted
capítulo
to
con la
close this
palabra de
chapter
la doctora
with the
María
words
Carmen
of
Calle.
Maria Carmen Calle. I wanted to
Haremos un
say
apelo a
that
que todos
we
los ministerios de
will
salud y instituciones que deseen intervenir pueden hacerlo nuevamente reconectarse.
have
Adelante,
a,
doctora María Carmen Calle.
you can reconnect. Dr. Maria Carmen Calle, my first words are to thank Dr. Bengolea and the Andean organism that have worked quite strongly
que lo regresamos a hacer después de 10 años.
to organize this forum. I would like to thank the Andean organization, the CDC, and and sincerely, I would like to thank Sylvain Aldieri from OPS Regional, Marcelo D'Agostino from Regional from Washington, and Oscar Feo from the Carabobo University in Claxo, Walter Curioso from the Continental University, Savara Bertram from the John Hopkins, and to the moderation of Patricia Garcia that moderated this first group, also to Andrea McCollum from the CDC, Jordan Cade from CDC, and Juliet Morgan. And also to Dr. Gabriel Carrasco from the University Cayetano Heredia, and also Dr. Rafael Lozano from Institute for Health Medic. And we have shared information. I think that the only message that we have after this forum is that we need to continue working. That is important. The opinion that we have of the specialists, we have from where you are. We are talking about the academia. We are talking about international cooperation. We are talking about the CDC, the Pan American Organization for Health, and everyone has been ready and present. The idea with the webinars and the forums that we are managing is learning, continuous learning. We learn, you learn. That is the main idea in this forum. We know that this forum is the beginning, not the beginning, but um, we know that you have been meeting among Latin American countries, and it's a continuation of the work that we should perform. So the public health surveillance has all the characteristics to become a tool that is valuable for decision making. We have been very modern, and we should not leave aside the social context. One of the main problems that we have in our region are inequalities. So I thank the work we had people from 18 countries, and that is super important because we know that together we are stronger, and together we can reach farther. So I think all of you, Lucho Bengolega, Ruby Diaz, Forley, and all the Andean Organization for Health. Also, we'd like to invite you tomorrow. We will have a forum on inequalities and the presentation of the publication of the Andean and the work and for consultation of disequalities in health. And we hope to see you, and good afternoon to all of you. Thank you very much.
Thank you very much, Doctor. I'd like to invite all of the delegates